This is going to be a voiceover lecture or PowerPoint for Chapter 11, which is covering adolescents in the Davis Advantage for Pediatric Nursing textbook. So the learning objectives we've already addressed for the other developmental phases. We're continuing to look at the growth and development that occurs this time in the adolescent population, as well as what are some age-specific things that we should be looking for, both in physical assessment and how we approach our interventions with these individuals, what are the appropriate health promotion practices and anticipatory guidance or education topics we want to speak to, and what are just some important concepts that we need to consider when talking about adolescent-specific emergency care, chronic care, and home care. And then the last bullet relates to what are some of the alternative therapies or complementary medicine that's being used by adolescents that we may need to bring attention to in our care of these individuals. So the first thing to know is what age frame are we talking about? And this is the end of the pediatric spectrum. So this is where we essentially see the child transition from childhood to adulthood. So there's actually 3 stages of adolescence according to your textbook that's broken down into year increments, beginning with age 10 and ending with 13, that being the early stage. Middle stage is 14 to 17, and late stage adolescence is 18 to 21. Now, for most of our information, we're going to think of the adolescent as the patient that's 12 and up, because the school age was from ages 6 to 12. So when I'm speaking about a patient who is 10 or 11, I am still speaking to that school age child, even though your textbook actually includes that in the early adolescent phase. We're going to pretend that school age ends at age 12 and adolescent phase starts at age 12, and then it will go as late as age 21. Outcomes that we're going to expect in development in this age frame are that they have way advanced cognitive abilities, that they are very autonomous or independent, and that they have an established self-identity. So our general survey, some things to know about the adolescent period, and this may seem kind of silly to think of it this way, but this is a period in which there is some sense of physical awkwardness because they're growing at a rapid pace. This is usually when the growth spurts occur in association with puberty for both genders. And so sometimes there's some fine motor coordination that's just not been perfected yet in this growth change. Their yearly maintenance visits include the same things we've been talking about, like height, weight, BMI, blood pressure, and screenings like hearing and vision. But we're going to add to that cholesterol screening. So this is usually the time frame in which they're going to start checking their cholesterol, and what you would expect is that their total cholesterol should be below 170. If there's a concern or a risk for TB, then screening for that would occur here, and that kind of makes sense for what we're talking about in terms of nursing students who are usually close to this the end of this adolescent phase, and they require it because of the program they've chosen to study. There are immunizations that are due in the adolescent phase. So we talked about school age being 11-year-old, and that's when typically the Tdap, the meningitis, and also the Gardasil or HPV vaccine are given. But then there's boosters needed for the meningitis vaccine at age 16, and now there are even some patients that are getting a different meningitis booster at age 18. Tdap is done then every 10 years. So if they received it at age 11, then the booster for that would be 21, which is the final year of this adolescent phase. Okay, in terms of Erickson, the phase that the adolescent is in is identity versus role confusion. And with that, I would best compare it to, well, and let me also say that there are different age frames for Erickson. So what they have actually said in his published literature is that industry versus inferiority is the 10 to 12-year-old. Intimacy versus isolation is the 19 to 21-year-old. And then identity versus role confusion is the 12 to 18-year-old. Well, we talked about that 10 and 11. We're going to let that still count in the school age. So that's why it will remain industry versus inferiority. So for adolescents, 12 to 18, identity versus role confusion, but 19 to 21 would be intimacy versus isolation. So with these, they want to be adults. They want to be independent, but they do still depend on family and caregivers and, need some help typically in this time frame. With the prefrontal cortex developing and, that's still going on, we would expect them to have critical thinking abilities and decision-making abilities, but there can still be some gaps in the development of those things. Characteristics of adolescents are that they're very self-conscious, they're very concerned with their self-image, they do a lot of comparison of themselves to others. There is an interest in sexuality and relationships that are both romantic and platonic in nature. Gender roles have been established at this point. This is when we see a lot of value and belief development. Unfortunately, this is also when we see a lot of injury associated with this mistaken sense of invincibility. So we have a lot of times where the thought process is, it wouldn't happen to me, I'm not going to be that person, I'm the exception. And so sometimes, that results in some careless behavior, some impulsivity. Sometimes it's related to mood swings. And sometimes it's just the need or the desire to test the limits and kind of see what they can get away with. And so, we see a lot of high risk behavior in this population associated with these characteristics. So what are our normal assessment parameters for adolescents? While they're, continuing to hit those growth spurts and develop in the puberty sense, then, we would expect that they reach adult values for vital signs. So usually there's little contrast between vital signs in an adolescent and vital signs in an adult, with an exception, and that is athletes. So when you have an athletic adolescent who is very conditioned, very, minimal fat on the body, their BMI is, pristine, then it's very typical for their vital signs to run differently than the typical adult does. They tend to have a lower resting heart rate. They tend to have a lower blood pressure, so they, and also slower respirations. So it may seem, different from what the average adult would have. As far as daily fluid needs for adolescents, the bolus fluid requirement, well, not really so much bolus, but the daily fluid requirement is weight dependent when the patient is above 20 kilos, which would be essentially, 40 something pounds. So the way that that's calculated is the baseline is the 1500 mils, and then you add a 20 mil volume for every kilogram above 20. So let's say the patient was, we're talking about adolescents, so realistically, we would say maybe a patient weighs 100 and, let's go with 100 and, well, let's just keep it easy, 100 pounds, okay? So for that patient, you want the difference in 100 pounds and 20 kilos. So 100 pounds in kilos would be something around like 45, 6. Let me go ahead and do the math for you so that I'm not giving you calculated. So what is 100 divided by 2.2? 2.2 is 45. Okay, so about 45 kilos. Well, we're not concerned with the first 20 kilos. that's represented by the 1500. So I'm going to subtract 20 from that. And that leaves me with 25 kilos. So I basically need to know that the patient's daily fluid requirement would be 1500 mils plus 20 mils for every kilo above 20 kilos, means 20 times 25, because that's the difference in amounts for them. So 25 times 20 would give me 509. Let's just say 510 for ease of addition. So 510 added to 1500 means that the patient would need roughly 2000 mils for their daily fluid requirement. I know that probably was hard to imagine because it's just being spoken and not, visually illustrated, but if you need to repeat it, rewind and write down as we go. Basically, this fluid requirement formula would be a great way for me to incorporate some math in the form of a dosage calc. I could tell you a patient's weight in pounds. You would then need to convert that weight to kilograms, and then you would need to figure out how much are they over 20 kilos, because that's going to be your math where you multiply that number times 20 mils and add it to the baseline 1500. We also talked about urine output when we talked about the school-age child, and I think even maybe the younger child as well. So for for adolescents, the urine output range is between 0.5 and 1 mil per kilo per hour. So if you were given a calculation problem where the patient's weight was told to you either in pounds or in kilos, you should be able to mathematically determine what is an appropriate output for that patient based on their weight. And doing that would mean multiplying it by 0.5 and multiplying it by 1 and determining if the volume that they're having in urine output is within that range or not. We would expect that these, children probably have the cognitive ability to utilize the numeric scale for pain rating. So asking them, like, imagine if you didn't feel any pain, to imagine the worst pain you felt in your life, where would you rate what you're experiencing right now? But if not, the FACES scale could still be relied on in this instance. We did talk about, with even the school-age child, how they'll have some school and home avoidance, and they might, blame it on different, what we call somatic complaints, things that are not, symptoms that are not easy to prove or disprove, like dizziness and nausea and headaches. I can't really determine if a person has that or not. I have to just take them at their word. When we see a lot of these kind of complaints associated with these individuals, a lot of times there's more to it. They're actually trying to avoid something, and so we need to try to, discover what's leading to that avoidance. They want their privacy respected, so definitely need to be mindful when we're coming and going from their exam room, that we're knocking, that we're giving them a heads up if they are sharing a space with somebody, that we're using the curtain. If they have caregivers with them, that we at least ask if they want the caregiver to be present while we do the assessment or while we ask the questions. Unfortunately, if they're a minor, we cannot force the caregiver to step out, even if that's the request of the adolescent. But we can definitely encourage or request that, and that we are using, confidentiality and providing that for the patients as well. When we're talking about body parts or medical information, we need to use the appropriate words for that, and then if explanation is needed, we can provide it at that time. Okay, what are some differences, growth and development related? So a couple things, like they would still be having their hearing and the vision checked for acuity. One thing that may be true of the patients who have some kind of corrective lenses, whether that be glasses or contacts, is that, the vision's going to change over time. If they're wearing glasses, the size of their head and how the glasses fit their face can change. So we need to be making sure that they're seeing those specialists regularly, and that if adjustments are needed, that we are making sure those happen. Typical for this age group to experience headaches and even possibly migraines. And so trying to, figure out the best relief measures for them, but also if there's any identifiable triggers that can be avoided. And then skin, we see a lot of changes during the adolescent period with increased sweat secretion and oily skin, usually resulting in acne. And so we want to encourage good hygiene so that hopefully, we're minimizing the chances of those things, but also infection as a consequence of that. Okay, in terms of their oral cavity, mouth, throat, and teeth, we do want to inspect for ulcers. Ulcers are oftentimes associated with tobacco use. Some kind of smokeless tobacco or an inhalant can cause ulcers in the mouth. Piercings, we know that to be a phase or a fad that typically overlaps this period. So education on hygiene associated with that and indicators of infection they need to watch for. Even just making them aware that, not only is it an infection risk having that, but they could have an allergic reaction. They could develop keloids, which is like a skin tag. It could even result in like nerve damage. If it's an oral piercing, it could create dental problems. So just making sure they're mindful of that before they hopefully proceed with some of those things. They should still be seeing a dentist regularly, every 6 months, having, cleanings. They may have gone through braces at this point and are moving into the retainer phase, though they may still be requiring braces. We see the wisdom teeth typically need to either be surgically removed or pulled at this phase to keep from, shifting anything the braces have done and potentially overcrowding. Sometimes teeth grinding is prominent in this phase, and so they may need some kind of guard, mouth guard at night to help with that. And then in instances where, there's not room for some permanent teeth, or like in the case of wisdom teeth to come in, then they may experience malocclusion, and that might result in the crowding or misaligned teeth. And so sometimes they'll do procedures to remove them if it can prevent that. Nose piercings, heart changes. The main thing is identify if anyone is a likely risk for iron deficiency anemia. We talked about several different developmental phases where iron deficiency anemia is the most common. It's in our infants when they get to be about 5 to 6 months old, because they've utilized any maternal stores they had, and we hope that they're going to be receiving iron fortified foods in the form of the cereal and oatmeal infants consume, and then ultimately baby food, so that it does prevent that deficit. We see it again typically or potentially in toddlers because of their tendency to drink so much milk and maybe still have the diet that includes iron-rich sources, but they're pairing it with milk and it's interfering with its absorption. And then we see it again in adolescents, oftentimes associated with their nutrition patterns, and with the, for females, the onset of their menstrual cycle. So identifying those that might need to be evaluated further and possibly given some kind of treatment regimen for that. Okay, in terms of their other major kidneys, the main thing is still a maturation occurring in that. There's a lot of development happening neurologically, but the frontal lobe is still not fully developed. Just like we talked about with the musculoskeletal, they can be somewhat clumsy. A lot of times that's due to the rapid changes like in growth spurts, and sometimes the fine motor hasn't caught up with those changes. We want to be doing a scoliosis assessment at this point, seeing if we identify any type of curvature. It's not unheard of for them to experience chronic abdominal complaints that usually are linked to stress and anxiety, but also we want to make sure that they're getting an adequate nutrition. With kidneys, UTI symptoms, and the genitourinary system are things to be mindful of, especially if the child or the adolescent is sexually active. And so we may need to give some education to that as well. Just note in musculoskeletal that the growth plates in the long bones typically close by age 20, so at the conclusion of the adolescent phase. Something else that you could watch for would be Russell's sign, which is knuckle abrasions that occur from the frequent inducing of vomiting. So sticking the fingers down the throat to try to throw up, which is typical of the eating disorder bulimia. Okay, reproductive. There's a little bit on this slide, but there's also a separate presentation that I'm going to voice over for you that is from chapter 19 that is encompassing a lot of the same information plus some. So with reproductive, things to note are, when they become sexually active and, even before sexual activity, the recommendation is that they have a gynecological exam and a pap smear, because we want to make sure that they're not having any indications of anything that would be concerning to their health, especially cervical cancer. Cervical cancer is what they consider one of the silent cancers. So a lot of times in its early presentation, it's not causing any symptoms. And so the only way you'd know whether or not you had it is a pap smear. So we want them checked. We want males checked for hernias. Hernias typically occur in the inguinal region of the male. We want to educate and also identify any indicators of sexually transmitted infections in either population. Know that with puberty for girls, it takes about 4 years for it to be completed. Boys a little bit less, but girls start first. So usually puberty changes occur in the girl before they occur in the boy. But both will ultimately experience growth spurts. For females, obviously menstruation is a big part of that. Puberty changes for both populations, hair growth, and that's usually legs, arms, underarms, and pubic region. And then for males, the deepening of the voice as well. What are some social changes? We talked about some important concepts to each phase. And so for adolescents, their body image or their self-image or perception is huge, but so is their peer approval or peer acceptance. Like they are very, very concerned with peer groups, and like they tend to hold more weight for the patient than family members do. We'll see a lot of conforming to what other kids are doing. That's why peer pressure is a concern. Definitely in this age group as well. They may start to challenge things like family values or traditions. They start to develop their own belief system of values and traditions. They are definitely influenced by their peers. They want independence, and sometimes that will result in conflict if they feel like they're not being given that. And it may lead to them resisting authority. They put a lot of emphasis on their relationships, both friendships and romantic. We see a lot of, clique formation, usually within the same gender. Like it might be all the ones in theater club or all the ones that, play a particular sport. Peer acceptance, gender roles, and sexual orientation are elements that are explored in this time frame. They may be working outside the home. They might be having a job while also in school, or they might be, not working to be able to focus on school. But, we see that they typically are trying to balance or juggle both of those. The internet safety element that is applicable to our younger kids as well as our adolescent population, but definitely being mindful of safe practices in social media, not putting all the information out there as to like where you're going to be and when you're going to be there, because obviously that can compromise your safety. You know, if they're making friends with strangers in social media platforms, you know, what kind of information are they divulging, and are they realizing some of that could result in some dangerous scenarios? From a spiritual aspect, they may start to question and even disagree with the religious beliefs they've been brought up in. They can have, you know, a completely different opinion than the rest of their family. A lot of times is when they start exploring, you know, that for themselves, and they may choose not to pursue any kind of religion. They do tend to have questions about and want answers to better understand death and afterlife, those things. And for some, you know, it's very important that they maintain a religious practice where they're, you know, keeping that as a priority in their life. Okay, medications. Some things to consider. Prior to now, everything has pretty much been based on the person's weight, the child's weight. And majority of medications we were looking for if it's safe in pediatrics. Well, now we're talking about adolescents, who some of which still definitely qualify for the pediatric, or what we would consider child, you know, label, but a lot of them would actually fit the adult as far as their size and their organ maturity and their ability to take these kind of medications. So things to know is that more than 80% of meds that are approved, you know, FDA approved, are not approved for use in pediatrics. So being mindful of whether this adolescent patient is still falling under what we would view as the peds population, which is a lot to do with, you know, are the organs mature enough for this medicine, and does weight impact the amount we recommend, before just deciding that, yeah, they're close enough to being the size of an adult, let's just tell them they can have it. And a lot of the reason that a lot of this is unknown for kids is because there's a lot of legality in testing it. I mean, most medications, people are not going to volunteer their children to be the guinea pig, you know, when things are trying to be used off label. So we have limited information. But meds can come in all different forms: eye drops, sprays, ear drops, oral meds that are, you know, chewed, that are tablets, or that are capsules and have to be swallowed. Could even, in some chronic need situations, give those meds intragastric or nasogastric. Rectal medications, especially like for a patient with epilepsy that needs like emergency diastat or diazepam, they would do that as a rectal injection. And I don't mean injection like a shot, like I mean like a rectal push of this. It's essentially like a cream. They could need injections that are intramuscular, subcutaneous, or even meds given intravenously. And the things to always consider is, like, with the child's size and age, like what's the likelihood of their metabolism or the medicine being absorbed and then ultimately being eliminated. That's going to dictate, you know, the amount that we're comfortable with for these patients. Keep in mind that puberty does impact metabolism. It increases it specifically. So that it's understood that most medications are metabolized faster in puberty and then slower after puberty, which would be like the, you know, adult time frame. Some variations to consider in nursing procedures. You know, we do still want guardian consent. If they're a minor, we have to have it. Patient assent is when basically the patient is agreeing to what is happening. They want this care. There's some definite, you know, blur or confusion as far as guidelines, especially in situations like emergency medicine, as to whether the parents have more say than the adolescent does, or if the parents even have to be involved, or if the adolescent can make those calls. And a lot of that is facility specific. So, you know, when you get out of school and you're working somewhere, you'll learn the protocol for those facilities specifically. Everything needs to be explained to them. We want to make sure we're honest and upfront about what's going on and what our explanations are. We're going to maintain confidentiality and preserve their privacy so that, they're not, that's their right. And then we still have to protect that. And if we violate that, it can still have very serious consequences. Okay, in your textbook is where this acronym comes from, called HEADS with 2 S's. And I would definitely advise you to memorize it. You will see questions that pertain to it when you get to this exam. The information is on page 206 in what's labeled critical component. And basically this acronym HEADS is meant to help you in remembering what all to assess and educate on for the adolescent patient. So like you're thinking health promotion, assessment, and education for the adolescent. So the letters stand for home, which includes the relationship they have with their parents, with siblings, maybe aunts and uncles live with them. What about the community, the school they're at? Are they involved in other organizations or sports or things that are contributing to, their routine? Education is the E, and that, means that we want to address any concerns related to their school performance. Could it be that they're being bullied? Could there be relationships that are toxic that they're involved in that setting? Those would be some questions to ask related to that. A for activities. So activities is, things like them driving and being a passenger with other people who are newly licensed to drive. Gun safety, water safety, safety with sports, like are they wearing the proper equipment? Are they aware of, what are some concerning violent situations? Do they have knowledge of how to try to minimize or prevent injuries? Research says that the leading cause of death in adolescents is the following 3 things: motor vehicle collisions or crashes, homicide, and suicide. And that's not, specific to, say, Louisiana. That's on a national level, but I mean, that's how sad the statistics are in relation to that. With safe driving, wearing the seatbelt, not driving while intoxicated or under the influence, being mindful of how many passengers are in the vehicle, not being distracted doing other things while driving. Gun safety, assume all weapons are loaded, never point them in the direction of somebody. Water safety, even in the adolescent age range, should have a buddy system. They should not be going into bodies of water alone. Having somebody with them in case something happens is obviously the safest. Know their limitations and know what safety devices are available nearby. Sports injuries, big things would be like concussions, sprains, fractures. So trying to encourage protection like helmets, pads, mouth guards, eyewear, footwear, all the things. Even just from a warming up and stretching before playing, don't play if you're injured, would also be some good advice. In your textbook on page 207 in table 11.2, there are signs and symptoms of concussions. If you're not familiar with those, you should definitely look over those manifestations. And with violence, we're talking about, violence in terms of like partner violence, like if they're in a romantic relationship, but also like gang violence, neighborhood safety, abuse at home by family members, any of those possible avenues. The D is for drugs, but also for diet, so it's kind of a dual representation. So this is, are they utilizing any tobacco, alcohol, or other substances? Abuse of prescription medications counts in that. But also, what's their diet like? Is it balanced? Do they have nutrient-dense foods? Are the foods high in, fibers, vitamins, and minerals? Are we keeping in mind their increased caloric need? If you remember School age was our like slump in terms of caloric need and energy expenditure, and now we're having that rapid growth and development again, and so that caloric need has increased again. Safe weight management, helping them to identify low fat or reduced calorie foods, talking about, what is going to help contribute to a positive self-image, making sure that they still maintain some adequate exercise or moderate activity will help as well. Drugs, we talked about tobacco, alcohol, substance use, but that also means like vaping, any nicotine substitutes, all of those things as well. And then the S's, one for sexuality, including safe sex practices like birth control, condom use, abstinence, ideally, mindful of how many partners, of what possible infections can be spread and being tested. And then also suicide and safety. So also considering, do they have any thoughts of harming themselves or harming somebody else? Are they depressed? Have they had suicidal ideations? What is the stress situation like? And do they have any effective coping mechanisms or relaxation techniques to help with that stress? And we want to be screening these adolescents for that, but also educating. Sometimes it's not an issue right then, but the issue may arise later. So educating on the potential for it and what management, techniques exist in advance. Okay, emergency care. One of the things to be mindful of is traumatic injury, especially in association with risk-taking behaviors, like the fact that a lot of times they do have this immortality and invincibility mindset that they're not going to be the ones affected, and they may just really lack the awareness between cause and effect. So we want to be, mindful of what all is considered prevalent injury issues. So that would be alcohol or substance overdose, whether intentional or accidental, motor vehicle crashes or accidents, whether they're the passenger or the driver, sports injuries, sexual assault, and then also just instability with mental health and how mental health can create emergencies for the patient who is needing medication and not taking it, or needs adjustments to their medications, or maybe have never been diagnosed and given prescription medications. Assessment considerations. In the emergency room, there was a act passed in '86 that's called the Emergency Medical Treatment and Active Labor Act, or EMTALA, which basically means that adolescents who require ER care can be treated regardless of consent from their caregivers. It also, EMTALA is the reason that when somebody is brought to an ER, they have to be treated there regardless of whether they have insurance or a means of paying for that treatment. We want to speak with the adolescent privately and provide confidentiality as much as possible. Times when that would not be the case is if it threatens their well-being or that of somebody else. We are first and foremost a patient advocate. We want them to be able to make whatever medical decisions they believe are best if we can. We can ask them for personal numbers or email addresses if we want to follow up with sensitive information that way instead of having to communicate through the primary caregivers. And we want to help facilitate discussions of topics that are sensitive, sometimes just among the healthcare provider and the adolescent, but sometimes with their parents. The nurse-patient relationship is very important, but it needs to be clear that the nurse is not the friend of the adolescent. The nurse is a professional who's, there needs to be clear guidelines and boundaries that are being maintained. We do want to provide an environment where they feel a sense of control, where anxiety is not heightened, where they feel like they have privacy, where they can ask questions and be given answers. But we also have to be, sure that there's that professionalism maintained. Equipment should be stored in like separate drawers and closets, not in the room, especially if it's a concern for somebody that, might be wanting to harm themselves or somebody else. Let's see. Got a lot of notes on this one, actually. It mentions distractions, so like we want to allow a separate space for adolescent patients to mingle. Like in some facilities, there's like a lounge. Like I mentioned Texas Children's last week. That's a great example. Other distractions might be some kind of games or even TV shows while they're hospitalized, because that's what we're basically speaking to here, is a hospitalized patient situation. Providing age-appropriate reading materials like magazines or novels. We want to encourage consistency with the patient's care, set expectations. If necessary, consequences may have to be there. They should be respectful, just as we should be respectful and non-judgmental, for trust development and rapport. We want them involved in their own plan of care. We want to be honest about, their treatment, the pain, the side effects, all the things. Okay, in terms of physical care, my notes include ensure the family and the teenager understand the condition and the treatment measures, so that they will be an active participant in their own care. As much as they can, we want to promote their independence and self-care, but when necessary, obviously coordinate services. And a lot of this is referencing a situation with a chronic illness. Caregivers can become very burnt out and burdened with that. So, we need to identify that existing and try to find other support services for them. This can include coordinating services between the medical providers, the school, and home for that patient. We want to be mindful of their developmental age. Sometimes that will not match their chronological age, especially with a lot of chronic illnesses in which growth and development is a delayed thing. So just because they might be 15 or 16 years old doesn't mean that they have the cognitive capacity of a 15 or 16-year-old. Providing and promoting self-esteem and confidence for them, allowing them to do some independent task completion. If we want them to still be pursuing their studies and like academic success, we want them to still have peer interaction if we can. We need to make sure that the expectations for them are realistic based on whatever their medical needs are. And sometimes referrals are necessary as well. Okay, for patients from a home care standpoint, home care, like home health, for example, decreases a lot of the financial cost. It minimizes travel cost, and it helps with caregiver burden because they can have sitters and nurses that come and do some of the work. So we want to, encourage that and help with that collaboration when we can. Caregivers may feel anxious having to be the one to do the skilled nursing that's needed for their child, and so by incorporating home care, home health, then that can alleviate some of that anxiety for the family. In terms of information technology, which kind of goes along with our informatics course you're taking this semester, but remember that these are tech savvy individuals usually, and so they're already exploring all the different applications available on their smartphones. They're involved in all the social media, and so it's very good to encourage them to stay atop of their care by getting into like a patient portal and being able to see where things are updated in their healthcare files, and that will help make them responsible adolescents that will become responsible adults when it comes to taking, kind of their health in their own hands. Let's see. And complementary and alternative therapies, also abbreviated CAM or CAM. It's typical for adolescents to deny use of complementary and alternative therapies, though they are likely to have dabbled in some of that. And so a good thing to, mention is that a lot of that stuff is okay as long as we know about it, so that we're aware of any possible, conflicts or contraindications with anything. And those can be a range of things like herbal remedies, yoga and meditation, homeopathy, or even like chiropractic therapy. Those all fall under this, like acupuncture, essential oils, all that kind of stuff. Making sure that we're making them aware that there are some things that you can take that are like natural and, herbal remedies that do, have a negative reaction with other things, other medications that might be prescription or even over the counter. And so, like St. John warts is a great example. St. John's wort. And the last slide speaks to child abuse. And I think we talk about that in other developmental phases too, but don't just think because they're an adolescent that they're exempt from being targeted in terms of sexual abuse, because the reality is it probably started younger. And, if that's something that they've encountered for years, it may be ongoing, even though they're now old enough to kind of defend themselves and to recognize the inappropriateness of it. And so, we want to help in that situation. And statistically, there is a very high rate of sexual assault occurring against adolescents. They're going to be less likely to report it because they'd be worried about retaliation from the perpetrator. They may doubt anyone's going to believe them. They may think that, they'll be blamed for it happening. They may not want to get somebody else in trouble. So some things to pay attention to is if they're having a lot of non-specific physical complaints, that could actually be indicative of sexual abuse. And unfortunately, even human trafficking needs to be considered. And like you'll see things like in the hospital, I was in early labor a week ago, and they had stickers, and it, basically it was in the bathroom where you would be giving them a urine specimen, and it says like if you are being sexually abused or assaulted, or if you've, had, if human trafficking is something that you're experiencing, then take the sticker and put it on your specimen cup. And that's like, a nonverbal way of communicating that need to the healthcare provider. So we want to, make sure that because it's a really real thing, that these adolescents are taking the necessary precautions. They go out with friends, they don't do things by themselves, they try to stay in public places that are crowded and within sight, avoiding alcohol and substance use that could compromise their judgment, probably a good idea, other things of that nature. And that is it for chapter 11 on adolescence. So there'll also be a voiceover PowerPoint to look at that talks to reproductive from chapter 19 and how that kind of correlates with the adolescent population that you can look at next.